Good morning and welcome to the Common Part B Nuclear Medicine Rejections and Denials webinar. I am Mary Moko and I'm a member of the WPS Provider Outreach and Education team, and I will be your presenter today. I'm joined by my friend and teammate, Bailey Lawson, who will assist with some behind the scenes help. Now, this particular webinar today is for people who are wishing to learn about the most common reasons for rejections and denials on Part B claims submitted to WPS by Specialty 36, that's nuclear medicine providers. CMS actually requires the Medicare Administrative Contractors, MAC for short, to include this specific education to prevent future claim rejections and denials. And just as advertised, the information that I'm presenting in this webinar is based on actual claims data. I'm going to pause for just a moment. Please stand by. Thanks for standing by, folks. I was picking up a bit of background noise and I had to remedy that situation, so thank you for your patience. I want to talk a little bit about some housekeeping before I dive into the presentation today. The actual slide deck is available to download from our live events webpage. The webpage address is in the chat. You can take time to download it now if you haven't already done so. We will record this session, and barring technical issues, we will post the recording on our Encore Presentations webpage, where it will remain for about 60 to 90 days. The recording will also post on our YouTube channel, where it will remain as long as the information remains current, or we otherwise decide to remove it for one reason or another. Now, if you have questions, please place them into the chat. If we have time, I will be answering those questions as time permits. But if I don't get to your question, I will email the response after the webinar, either directly to the learner that posed the question, or I'll prepare a list of all of the questions and answers and share them with all participants. Now, if you have a question on a specific claim that is processing, one that already denied, or otherwise sent to Medicare, I am unable to provide an answer. The reason for that is provider outreach and education, like Bailey and myself, we do not have access to the claims processing system. We are unable to see claims history or look at a claim to assist you. That is actually a task based on CMS directions of customer service. So they are available if you need to ask a claim-specific or provider-specific question. They can access those claim details in the claims processing system, and they're able to help you with those types of questions. Now, we include this disclaimer in all of our live events. The presentation today is for educational purposes only, and I did make every effort to verify that the information that I'm going to provide is current and it is accurate. But I do need to let you know that it is subject to change. It is on the CMS website that you will find the Medicare rules that determine final coverage, and those laws, regulations, and rulings are what will always prevail. Just one final reminder before we get started. CMS prohibits recording of this webinar for profit-making purposes. We ask that you do not record this presentation. We will create an encore of the presentation, and you can use that for future reference. Based on the American Medical Association's copyright notice for CPT codes descriptions, and other datas, I've included this CPT copyright notice in my presentation materials. Your continued participation in this presentation today infers that you agree to the terms of this copyright notice. All right, let's get started with today's presentation, beginning with our agenda. This is what I advertised that I'll be discussing or talking about during today's presentation. I'm going to define rejections and denials. I'm going to reveal the reasons for the most common rejections and denials for Specialty 36, that's nuclear medicine, based on actual WPS claims data. I'm going to discuss how to fix and avoid those common rejections and denials. And I'm also going to provide resources. Now, in order for me to discuss rejections and denials, I do need to provide a bit of information about the claims process, so that's where we begin today. Based on a law that requires it, most providers submit claims electronically. Upon doing so, there are reports that generate to confirm the claim receipt, and they'll also report more specific information with data requirements. Now, one of these reports is the 999 that is used to confirm claim receipts. If you use a clearinghouse, they may be looking at these reports. The Medicare 276, 277 report is also used. I know I have 277 here on this slide, but the 276 report also provides specific information. We do have a companion guide. That guide was prepared by our Electronic Data Interchange, or EDI staff, and it helps submitters understand the claim requirements and know when they need to correct or resubmit the claim. So just a little bit of information about some of those front-end edits that occur when you submit your electronic claim to Medicare. We call these pre-pass edits. Now, claims that move past the pre-pass edits will generate a remittance advice. It's also referred to as the RA. Sometimes people call it the remit. Some people simply call it the notice, but it is that remittance advice that is sent to providers that explains how the claim was processed. Now, there's two formats. One is the electronic remittance advice, or the ERA, and there's also a standard paper remittance, or SPR. Now, with few exceptions, most providers are going to receive that electronic RA. The RA provides information that's very important to the provider. As we're talking today specifically about rejections and denials, you're going to need, or providers will need to look at that RA to find information about any adjustments or denials, missing items, refunds, and sometimes even offsets when that claim is processed by WPS. When looking at a remit, you're going to find various reason and remark codes. These are typically in an alphanumeric format. When claims pay differently than billed, a claim adjustment reason code is going to appear on the remittance advice, and sometimes a remittance advice remark code also appears, and the remark codes actually expand on those details that are described by the reason code, and it's to provide more details about the adjustment to the claim. Another type of code on the remittance advice that's important to take note of is the group code. Group codes are those codes that assign the financial liability for any unpaid balance on the claim. There are two different types of group codes. The CO is contractual obligation. That means the provider is liable and can't bill the patient. If you see a PR group code on the remittance advice, it'll note that the patient is financially responsible. Let's talk a little bit about the maintenance of those reason remark codes and group codes. WPS hears a lot of comments about these codes, and providers often state or share with us that the codes are too cryptic or that they contain outdated acronyms or information. Well, we'd really like to help. There is another contractor, not a WPS, who maintains these codes for CMS. You can find a link to the code lists on their website. They are the Washington Publishing Company, or WPC. It is on the WPC's website where you can find contact information should you wish to submit a change to the, or suggest rather, a change to the code list. Excuse me. There, I needed a drink of water. Sorry about that, folks. It is on the WPC's website where you're going to find those code lists. There's also links to find contact information should you wish to suggest a change to any of those code lists, including those code explanations, some of which some of our providers have called cryptic. Now this slide shows you a slide by slide, or side by side, slide and side by side. It is a side by side comparison on a slide of a rejection to a denial. Let's take a look at rejections first. On the left-hand side of this slide, we call these, or CMS calls these rather, unprocessable. They're never really processed. It's a claim that can't be processed, although there is a remittance advice that generates. It's returned on what we call the front end. The reason it's being returned is because something's illogical, it doesn't make sense, there's something missing or incorrect. Because a rejected claim or an unprocessable claim is never really processed, there are no appeal rights. We can't do an appeal on something that wasn't processed, right? What you need to do is fix it and resubmit it. Now, I talked about those reason and remark codes and group codes a bit earlier. For rejected claims on the remit, you will find an MA130 and a C016 code. That should be a little flag up in the air for you to note that that particular claim or claim line was rejected. It was unprocessable. The patient cannot be held liable for those services. You do need to fix it, resubmit it. A denial, on the other hand, is a claim that has been adjudicated. It's been processed. Denials take place because of failure to meet payment criteria, and there are some examples listed here on this slide. First one is statutory requirements. That means that there is a law that states this doesn't meet payment criteria, so Medicare is going to deny. There's also those medical necessity denials. Medical necessity denials are tied to payment policy. Frequency edits, utilization parameters are a form of medical necessity. There are also eligibility denials that occur, and this could be for the patient not being eligible or that beneficiary not being eligible the day the service was rendered, or it could be that the provider was not eligible. And when the provider's not eligible, it can be due to a number of reasons. When you receive a claim or receive a remittance notice for a claim that's been denied or claim line that's been denied on a claim, you're going to see, among other codes, the MA01, and this code provides appeal rights. Is it there all the time? The answer is no. It is most often on a claim denial, but there are just a few exceptions where there is no appeal right for a denied service, and I'm going to talk about one of them a little bit later on in this presentation. For denied services, patient liability is determined. All right, let's take a look at, on the next slides, whether you'll need to correct or appeal the claim decision. Now, after reviewing an RA, you are going to need to choose your actions. Now, for an unprocessable, one of those claims that's been rejected, you're going to need to fix the error and resubmit the claim to Medicare. If the claim or claim line denied, there could be multiple actions to choose from. You may be able to simply resubmit the service. You might use the clerical error reopening or SIR process to fix clerical errors, and CMS defines clerical errors as human or mechanical errors on the part of the provider or the contractor. Another action to consider is an appeal. The remittance advice will provide those appeal rights with few exceptions, like I just mentioned. Registered users can use our SecureNet Access Portal, or what we call SNAP, to render or request a clerical error reopening or to request an appeal. And these are just a couple of the self-service tools that SNAP offers for the most efficiencies for providers. And we do have a portal user manual that provides illustrations and also step-by-step instructions on how to use these portal features. You'll also find some videos on our YouTube channel that will help you with any questions you have about the use of the SecureNet Access Portal, or SNAP. Now, Bailey has placed a link in the chat to an article we have available on our website if you're interested in more information about those clerical error reopenings. It's a really nice article. I like it because it explains the process. It tells you these are examples of those claim adjustments that can be done using this clerical error reopening process, or reopenings I should say, that can be done. And then it also provides examples of those things that we cannot use this process for. It gives you information about using SNAP to do this or to request this, and also how you can just contact us and we'll do or take care of that clerical error reopening for you. All right, I do have a bit of information that I placed here about appeals. And I didn't advertise we were really going into the appeals process during this webinar, but we have tons of information available on our website and on our YouTube channel. One of the resources on our website is then included on the next slide, and it does include information on all 5 levels of appeal. You'll see here on this slide there are 5 levels of appeal. MACs render only level 1 appeals. They're called redeterminations. All 5 levels of appeal have time limits to file the request, and there's also time limits that CMS has instated for completion of those appeals. There are 2 levels of appeal that have an amount in controversy. That's a dollar threshold that applies. Those 2 levels are level 3, the administrative law judge hearing, and level 5, the federal court review. And I'll talk more about those in just a minute. I mentioned to you the resource on our website. It's called How to Appeal a Claim Determination, and this is hyperlinked. So if you've received your presentation materials, you can simply click on it and open that very, very helpful resource. And I also want to show you one of my personal favorites. Whenever I talk to an audience about appeals, I like to talk about the CMS fee-for-service appeals process flowchart. This is a flowchart, and I'm going to click on the link and show you how easy it is to open it up. I actually opened up on my other monitor, so I'm going to pull this over, make it a little bigger for you to see here if I can drag it here. This particular flowchart is one I like to share because it shows both the standard process for the initial determination appeals process and the expedited process. Today, for this webinar, I advertised it's for Part B providers, those that submit claims on the 1500 claim form or the 837P. So I'm talking about Part B. So we're going to stick to the standard process because the expedited process applies only for some Part A claims. But I told you there are 5 levels of Medicare appeals, and they show here. Here's 1, 2, 3, 4, 5. It provides you with the name of that appeal level, the MAC redetermination, the qualified independent contractor reconsideration, and the Office of Medicare Hearings Appeals, and so on and so forth. It tells you the time frame you have to file that appeal level. 120 days, 180 days, 60 days, and so on. It also tells you the time frame that the contractor has to render their decision on that appeal request. So for example, the MAC redetermination, we have 60 days to make a decision or render that decision on that appeal request. 60 days for the quick level, and so on and so forth. Remember that I mentioned to you those amounts in controversy, those levels or those dollar thresholds that you need to meet in order to request an appeal. Those apply for two levels of appeal, level 3 and level 5. Um, you can see on this chart, and this is why I like it so well, that the amount in controversy for the level 3 appeal is greater than or equal to $190. The amount in controversy for federal district court is listed here, greater than or equal to $1,900. Remember that I mentioned to you this is updated annually, so you'll want to pay attention to this. It tells you right here, this chart reflects the amounts for calendar year 2025. At the beginning of next year, some of this information could change. Most often it's the amount in controversy that's going to change. Sometimes it doesn't change, but it can change for each calendar year. And you want to pay attention then, of course, to make sure that you're viewing the correct information if you're using this very handy chart. All right, Flowchart. One of my favorites. All right, let's talk data now. This is the next portion of today's webinar. I advertised that I would reveal the most common reasons for rejections and denials for specialty 36. Now, these may be the same rejections or denials that are happening within your organization. And maybe they're not, but the important thing is that CMS wants us to provide education about this to avoid these. These are the most common rejections and denials for specialty 36 nuclear medicine. We want to make certain that you know how to fix them and even avoid them so they don't continue to occur. The data dashboard is a tool that I use to pull this information. It is an interactive tool. It was designed by our data analysts in a department at WPS that's known as Insight. Insight is the name of their unit. They're responsible for a number of tasks, including to mine data, identify data trends, look for vulnerabilities. They also work very, very closely with both our policy staff and our medical review staff to determine if the edits and audits that we put into place are working, are bringing down those levels of rejections and denials. Are they making certain we're processing claims correctly, making those correct payments that providers are entitled to? We want to make certain of that. And of course, there's other tasks and responsibilities, but I use the data dashboard. There are different ways to use that data or to view that data dashboard. I can't show it to you now because it's only accessible from within our secure Citrix system. I can't take you out to our secure system to show you anything, just to make certain that we're not touching on any PHI or PII or any secure information that we can't share with anyone. Using this particular dashboard, though, we can, in an instant, I mean just by hitting the enter button or using our mouse, clicking our mouse, we can drill down various ways of viewing that data or drill that data down by state. We can do it even down to counties. We can also look at reasons for rejections or denials. We can look at top or most common rejections and denials by CPT code or HCPCS code, and even by specialty. And that's really what I've done to present this data to you today. We can also look at trending, and trending alerts us to those spikes or increases or even decreases, but mostly we're interested in those spikes in rejections and denials so that we can make certain that we're providing the education needed to avoid those in the future. Make sure we're processing claims correctly, providing that payment to you that you're entitled to. So here then begins that actual data that I said I would reveal during this webinar. I'm going to talk about those most common reasons for claim rejections and later denials. Then I'm going to discuss the ways to fix or avoid them. So the number one reason claims are rejecting for specialty 36 or nuclear medicine claims is that there was an invalid or missing modifier. 544 of them in the time span that I looked at. And I neglected to tell you that the data slicers I used were all states in jurisdictions 5 and 8 for specialty 36, that's nuclear medicine. These are claims submitted February 1 of 2025 through April 30 of 2025, and this data was last refreshed. They last refreshed that data dashboard on May 8th. That's when I pulled the data together, analyzed it to present to you in this webinar. I apologize, I skipped over that along the way. But here then are those common rejections and reasons. I'm going to back up just a minute to this slide too, to tell you, for some of you that are on this webinar today might be wondering, what is she talking about specialty 36 for? What does that mean? For those of you that are wondering what a specialty code is, it is a code assigned to WPS providers when they enroll with us. Now, during enrollment, most providers self-designate their specialty. While most providers can designate a secondary specialty or even a tertiary specialty, it is only that primary specialty, the one designated, that is used during initial claim processing. There are some situations, of course, where a provider will request an appeal and stipulate that they have a secondary specialty allowing for Medicare payment, or which should allow for Medicare payment. But during that initial claims processing, the claims processing system can only look at one specialty, and today we're talking about specialty 36, which are nuclear medicine claims. So back to those top rejections. Remember, these are unprocessable. They're never processed. What you need to do is fix it, resubmit it. So invalid or missing modifier was our top rejection reason for the data I looked at. The second reason we rejected specialty 36 claims was that there were no submitted charges billed, 0 charges. Missing, incomplete, invalid name, strength, or dosage of drug is the next most common rejection. Incomplete, invalid plan information for other insurance is next with 9. And missing, incomplete, invalid ordering primary identifier, that's the ordering provider identifier, 6. Payment included in another service received on the same day is a form of bundling. Sometimes we call this bundling. And another is that the claim must be sent first to the employer group health plan or large group health plan. And I did use acronyms on this slide, but the reason I did so was because those acronyms are what prints out on your remittance advice. So I wanted it to show or look just exactly like what you see on that remittance advice. Here are the most commonly rejected codes for specialty 36. I wanted to go a little bit deeper and provide you with the codes and the reasons why they are rejecting. The top rejected code for your specialty is 78815. That's a CPT code that describes a positron emission tomography or PET scan with concurrently acquired computerized tomography, so on and so forth. And this is for or covering the area from the skull base to the mid-thigh. This code commonly rejected for the invalid or missing modifier. The next reason it rejected for was missing, incomplete, invalid ordering primary identifier. For these services, CMS says the ordering provider must be shown on the claim. If it's missing or incomplete or invalid, maybe it was keyed wrong, that claim is going to reject. Here's the next one that I wanted to point out, and this didn't make the top 7 of the most common rejections, but for this code it did. The third most common reason this code 78815 rejected was because the claim had been forwarded to Palmetto RRB. Similarly, down here for 78816, you're going to see claim must be submitted to United Mine Workers of America. These are situations where another contractor, not WPS, should process that claim. So the claim would be rejected if it is a Railroad Retirement Board claim that should be processed for a Medicare beneficiary who's retired from the railroad. There is a special Medicare contractor that processes those railroad retiree claims. It is Palmetto. So in this case, you don't need to submit the claim to Palmetto. For this reason, the claim has been forwarded already to Palmetto for you. 78816 is the PET scan also. This is the second most commonly rejected code for your specialty. This is the PET scan, of course, with CT. And it's the same, but it is whole body as opposed to skull base to mid-thigh. Top reasons: invalid missing modifier, and the one I just talked about. The claim must be submitted to United Mine Workers of America. I'll show you later when I talk about those resources or ways to fix and avoid, how you can find information or an address for United Mine Workers of America, or learn how to submit claims to them. 78814, very, very similar service. It's a PET scan with CT, but this is for a limit area such as the chest or head and neck. And that one, the only rejection that showed up for that 3-month period that I mined data for, is invalid or missing modifier. Another code commonly rejected is this one, the J7030. This is a HCPCS code that describes an infusion of normal saline solution, specifically 1,000 cc's or milliliters. It's used to indicate the patient's receiving an IV saline drug. We rejected this code because no submitted charges were billed. The notice on the remittance advice says resubmit a new claim. Now, maybe the reason there were no submitted charges billed was because this service may be one that's not separately covered, so the provider was simply showing us that this service was provided and didn't put any charges because they know it's bundled, you can't bill for it. But in those cases, you really don't need to submit the claim at all to Medicare, or that charge to Medicare, if it's one that's bundled, always bundled, and not payable by Medicare. A9597 is the next commonly rejected code for Specialty 36 claims at WPS. This is PET radiopharmaceutical used for tumor identification, specifically for diagnostic purposes and not otherwise classified. It's an NOC code. It is used in conjunction with PET scans to help identify and locate tumors in the body. And effective for claims with dates of service on or after January 1 of 2018, we need to make certain that these tracer codes are present on a claim. That also includes other PET HCPCS codes. When that combination of billing is submitted to Medicare, there needs to be modifiers submitted on the claim. Either the PR or the PS modifier is appropriate. So it only stands to reason that the top reason and only reason that printed out in the data I mined for this code, the A9597, was an invalid or missing modifier. So you need to fix it, resubmit it, put that modifier on there, and submit that claim back to Medicare. J2785 is the code for billing of the administration of, not sure I'm going to say this right, folks, and I looked for how to say it but couldn't find it, regadenoson. It's a pharmacological stress agent known by the brand name Lexiscan. This was rejected because on that claim there was missing, incomplete, or invalid information. We need the name, the strength, and the dosage of the drug when billing it for Medicare. You need to also remember to consider if a modifier would be appropriate, which would include a JW or JZ for those single dose containers. I wanted to show you also the one example of trending for rejections. The one that I chose was missing, incomplete, or invalid ordering primary identifier. And remember, I'm going to talk about how to fix or avoid these in a little bit. That trending information that we can look at and analyze at the click of a button shows us the top reasons or trending for specialties in this case, because I looked at specialty 36 and I pulled out this reason for rejection. There was 6 claims the current 3 months, 2 in the prior 3 months. That is an increase of 4 claims during that 3-month period, which represents a 200% increase in rejections for that particular reason. So this is what I meant earlier about using the data to look at trends and determine what kind of education we need to provide. All right, I talked about and revealed the most common rejections. Now I am going to talk about denials. And whenever I educate for rejections and denials, sorry about that, I want to make certain that I let you know that it really is important that you recognize the difference. And remember, I showed you that slide earlier that has the side-by-side comparison of rejections and denials. Many people use these words interchangeably, and we really shouldn't because they're very, very different. Rejected claims are unprocessable, never processed. Fix it, resubmit it. Denied claims, you might be able to fix and resubmit it, but there are other actions that you can also consider for fixing or receiving payment for that item or service. Let's take a look at those most common denial reasons for your specialty. The number one reason your specialty claims were almost caught myself there, re, um, denied, not rejected, we're talking denials now, is that Medicare will not pay for this service for this condition. This, folks, is a policy rejection. Uh, Denial, I caught myself again. This means that Medicare will not pay for this item or service, and there would need be a policy, a Medicare policy of some sort that says Medicare can't pay for this service for this condition. There would be an edit within the system. Anytime there is a policy, whether it's a national coverage determination or an NCD or a local coverage determination or LCD, that means there's edits. Policies equal edits. There's edits in the claim processing system to make certain that that service is payable for that condition. The next top denial reason for your specialty is collection of fee-for-service during periods of managed care. And that one, folks, I would have to agree with anyone that called us and said, that's a little cryptic. It is. I verified that this means it is denied because the service should have been submitted to Medicare Part C, a Medicare Advantage plan. That particular beneficiary has chosen or elected Medicare Part C, not Medicare Part A and B. That MACs process, we process Part A and Part B claims. We are a MAC. We do not process Part C claims. And in this case, the service was denied because the service was during a period of managed care. Look at the next one, duplicate charge paid. There would be a date here on claim, and here would be an internal control number that signifies a specific claim in the payment system or in the system or already you're right, already paid. Duplicate denials continue to kick us in the pants. This has been happening for as long as I have worked in Medicare, which is many, many, many years. Duplicate charges can be avoided. I'm going to talk about them a little bit later, or duplicate denials can be avoided. I'll give you some good tips on that a little bit later on in this presentation, but I do want you to recognize it continues to beat us up. Providers are spending a lot of money submitting duplicate claims only to be denied. If it's a duplicate, it's going to deny again and again, unless maybe there's a modifier you can add that tells us then that the service really isn't a duplicate. But for the most part, it's going to deny and continue to deny. Or historically, that's what happened. It costs you money. It also costs the Medicare Trust Fund to process these claims. And there are thousands and thousands of these denied every single day. Now, only 62 for your specialty, but for some of those specialties that submit a greater volume of claims, that's a lot of duplicates out there. And we all need to save those costs, both providers and we want to save the Medicare Trust Fund as well. So let's eliminate those denials. The next most commonly denied claim reason for your specialty is that the claim must be sent to the EGHP first, Employer Group Health Plan. That means the beneficiary has an insurance that's primary to Medicare. You need to send it to that insurance first before Medicare can consider payment. I apologize there. Expenses incurred prior to coverage, 38 denials there. So things you can do, we'll talk about those later. Here are the most commonly denied codes for your specialty and the reasons. These reasons are not new because they hit the top Most common reasons for your specialty denials: uh, the CAT scans, or PET scans rather, with CT, 78815 and 14, not medically necessary. Medicare will not pay for this service or this condition. That's policy, folks. Look at the policy to see if Medicare will pay for that CPT code for the ICD-10 or diagnosis code submitted on your claim. You can see some MSP type denials here for 78815, that being claim must be sent to the EGHP first. There's that duplicate charge already paid on another claim. Medicare does not pay for this service in this facility is a reason that 78814 denied. You're going to want to look at where that service was rendered. Or did you report the place of service correctly on your claim? Things to think about. Let's move on. 77080 describes a DEXA scan or DXA scan of the axial skeleton for bone density measurements. This code is denying because it's not medically necessary based on Medicare guidelines, or the claim must be sent to the EGHP first, or that beneficiary has elected Medicare Part C, and it is a period of managed care. Part C should be paying for that claim. 78816, another PET scan with CT, whole body this time. You can see it's denying due to policy. Check out those policies on our website or on CMS's website to make certain which services are covered for what diagnoses. If it is a service and you believe the likelihood that Medicare is going to deny due to medical necessity rules for Medicare, you do need to consider presenting your patient with the ABN, the advance notice of non-coverage, to that, or the advanced beneficiary notice of non-coverage, the ABN, and you need to do so before the patient has the service. And this isn't just specific to 78816, but anytime a service is denied due to medical necessity, you should be considering whether or not to present your patient with that ABN. Then of course, you would need to follow all those rules specifically and report the correct modifier in your claim to show that there's an ABN there or isn't, or that you forgot to give the ABN, so on and so forth. Claim must be submitted to EGHP. That's another Medicare secondary payer denial. 78452 is myocardial perfusion imaging using tomographic single photon emission computed tomography, specifically for multiple studies here. Duplicate collection during periods of managed care, so patient has Medicare Advantage, don't submit to Part B. And typically these would be something where the information may not have updated properly within the common working file, which is that master computer system that CMS keeps. So the eligibility dates may have been off, and we might have paid for the service, or it might come back that the service shouldn't be paid because it is indeed during managed care. Sorry, I got ahead of myself here. And then of course, wait, we were on the 452. For some reason, I keep slipping with my mouse today. I'm so sorry. Claim must be submitted to the EGHP. 93010 is the last of the codes that made the top list for denials for your specialty. And this, of course, is the interpretation and report of an EKG, specifically for a routine 12 lead or more ECG or EKG. And this is denying because the information does not support the need for the item or service. That's a form of medical necessity. This is a duplicate charge and date of service filing limit. So something we'll talk about in just a bit. Here is that trending example for specialty 36, and this is just similar to the denial I talked about on the previous slide. The time limit for filing your claim is expired. There is no appeal right. This, folks, is that exception I talked about earlier, where there is no appeal right. There's no appeal rights when your claim is denied due to timely filing. Current 3-month claims, 12. Previous, 12. There's no change. And this is good news, and I'll tell you why. WPS has been go here, Topic Center. We have, I'm going to the home page here. We've been doing webinars about timely filing of claims, and I just did a simple search of timely filing. You'll see that the number one and the results comes back is the timely filing of claims. And this is included in the resources in your presentation materials, so you'll be able to find this. It is on our website. This talks about timely filing. You have 1 year from the date of service to submit a claim to Medicare. One thing I do want to point out, and this is something that we hear often from providers, and it's right here. Denied claim not filed within the time limits due to a third-party error. And this happens often. This happens when providers ask us to reopen a claim for timely filing because another insurance recouped their previous payment, and that's what caused the delay in submitting the claim over to Medicare. At the time of the service, you had reason to believe that another insurance was primary, they made payment. Now, even as much, we've heard this from providers, even as much as 6-7 years, they're coming back and say, hey, we need our money back, Medicare was primary. In the CMS Internet Only Manual publication, that's one of their online manuals, it's the Claim Processing Manual. Here's a link to that within our article. Section 10.11 states this: CMS says that an error or a third-party error in making that primary payment does not constitute good cause for reopening your claim. And this is why, even when you had the information that you thought you believed was correct, this is the information that tells the MACs that we can't reopen that due to that third-party error. Now, there sometimes are cases where you have good cause for reopening a claim, and this article also tells you how to do that. So I just wanted to point out that this is good news when we look at this trending. This shows that the education we're providing is working. Okay, at least for specialty 36 claims. So kudos to all of you. This section now, the next slides, and I'm going to go through these really quickly because they really are straightforward. These are the fixes: fix it, resubmit it, and what you need to do to make an appeal and receive payment on your claims for denied services. Fixes are for rejected services. Excuse me. These are really straightforward. For modifier issue fixes, make sure that a required modifier is present. Make sure that modifier can be billed with that procedure code. And make sure that the modifier was valid for that date of service. Eligibility fixes, use patient eligibility records. Make sure the patient name and their number exactly match on the claim. And make sure you're submitting services to the correct payer. We had this pop up for your specialty. Claims should be submitted to Railroad Board. Claims should be submitted to United Mine Workers of America. Beneficiary has a Medicare Advantage plan, so you need to submit it to the plan. CMS has on their website an interactive claims directory. I'm going to show you that later. And well, I'm going to point to it in the presentation. You can click on any given state. So if you're a Michigan provider, click on Michigan. It tells you who is the Railroad Board contractor, who is the United Mine Workers of America contractor, who's your MAC, who's your RAC, your Recovery Audit Contractor. It tells you all the names of the various Medicare contractors for that particular state. So it's really a great resource. Provider number fixes. Make sure you're entering that number correctly. You didn't key it wrong. Make sure your enrollment records are up to date. Sometimes a rendering provider is not associated with a billing provider. Make certain that's in the provider enrollment records. And this one is one that kept hitting for your specialty. Ordering provider needs to be entered on the claim, and it needs to be entered correctly. I'm going to show you a resource where you can find a list of all providers who are eligible to order or refer services for Medicare. It's a CMS file. It has all of the providers listed. You can search it for any provider, and it gives you their NPI, their National Provider Identifier. Here, folks, identify duplicate denials. I told you I was going to give you more information. Make sure that there's no modifier that you should be submitting that really tells us it's not a duplicate service, but it's rather a repeat by the same provider or repeat service by another provider. The first bullet I want to point out: no auto resubmitting prior to establishing status. Look at those remit notices, and be aware of the status for your claim. Don't just automatically submit on a cycle. If you use a billing service that automatically submits every 30 days, tell them to stop doing that. That is considered abusive, and repeated forms of abuse is considered fraud. So we need to do our due diligence to avoid these duplicate denials. We have resources on our website that speaks to these. I'll point that out in a minute. MSP denials. There's some great information out here listed here. Fact sheet, questionnaire. All of these address avoiding denials due to Medicare secondary payer situations. We're not delving into this today. I'm telling you this, giving you this resources, providing you with the knowledge that there is an MSP playlist on our YouTube channel that will help you avoid these denials. Bonding was a reason why your claims are denying. That's typically due to the National Correct Coding Initiative edits. So I provided those resources available here for you. For bundling, you would want to look at the relative value file to see if it's a code that is a status B code, always bundled. It's never going to unbundle. But sometimes there's situations where there's procedure to procedure code edit, where there's those two codes billed on the same day by the same provider during the same encounter for the same beneficiary. You need to use those procedure to procedure code edits to see if there's an indicator that says that you can append a modifier to the column 2 code in order to unbundle payment for those services. It says you may, but it doesn't say do it. You need to look to see if it's okay to append the modifier, and then look at your medical record documentation to make certain it justifies the use of that NCCI associated modifier. Resources and tools. I'm at 10:53, so I'm going to move quickly. I will give you ample opportunity to submit questions if you have them, and I'll tell you how to do that later on in the presentation. But here are resources and tools. Here are requirements for submitting claims to Medicare. I've included for paper claims, for electronic claims, and so on. I've also included this crosswalk, and I do want to open this, which shows you, I'm going to pull it over. This is a crosswalk that our EDI department put together. It crosswalks a paper claim to an electronic claim. So in the first column is the item number on a paper claim, and then it crosswalks to where on an electronic claim that information needs to be. What's particularly helpful in this crosswalk and helps you avoid rejections, because you know you need to put something there on the claim, is this status code column. If there's R, it means it's required. It needs to be there or your claim is going to reject. If there's an S there, it means that it's a data element that must be completed if other conditions exist. In other words, it's situational, and that's right here at the bottom of every single page. So that's our crosswalk. That's going to help you know when you need to place information on the claim in order to avoid a rejection. We have our IVR, and this is here because you can find claim status and details 24 hours a day, 7 days a week. This is the tool where you use your voice or telephone keypad. There is an IVR operating guide available to help you use this. Similarly, you can check claim status, claim details, learn more about denials by looking on SNAP. You can also check eligibility 24 hours a day, 7 days a week, limited functionality outside normal business hours. And we do have our portal user manual available. You can go to any page on the WPS website. Let me pull this open for you here and link to that portal user manual by going to the bottom of the page. There's a link right here under educational opportunities, or at the top of the page, the link is right here in this user logon box for SNAP. There is the portal user manual. All right, let's look at this. Is a resource on our website. It's an article. It tells you how to correct a rejected claim. The nice thing about this article is you look at that remit notice, you'll see all those reason and remark codes on there. If it's a rejected claim, come out to this resource. When you scroll down here, and this is just a screenshot, there's actually a listing of reason and remark codes, and it tells you this is how you correct the rejected claim. Similarly, we have a resource on our website that speaks to denials. Remember, denials are really different from rejections. These we list those same we list reason and remark codes also, but we categorize them. So we put reason and remark codes related to bundling together. We put reason and remark codes related to global surgery or duplicate claims together. And we tell you how to, the actions you need to take to avoid them. Website is our resource. How to request a clerical error reopening. This is that resource I talked about earlier. Explains the process, tells you what is eligible to do or what type of correction you can make by using this process, what type you don't have to. We have a modifiers web page. Let me just trying to get to it here real quick. Out on our web page, I want to show you the fact sheet that we have available that speaks to the PET imaging modifiers that are required on claims. Definition, right here it is. Appropriate uses. Here's inappropriate uses. So we have this fact sheet for these PI and PS modifiers, but we have tons of fact sheets for other modifiers as well, if that is an issue for you. Timely filing of claims I showed you. The crosswalk I showed you. They are great tools. We have live events announced on our live events webpage. That's future education should you need it. Encore presentations are recordings of our webinars. And of course, we have our YouTube channel with those great playlists, MSP, Medicare Advantage plans, and more. E&M, Evaluation and Management. The last I looked, there was over 45 recordings just on E&M alone. Other resources, we have a fact sheet that speaks to checking eligibility. There were some eligibility denials listed on your top reasons here today during this webinar that I talked about. Here's that interactive contractor directory map. I opened it up, going to pull it over and show you. Remember, I mentioned click on your state. If it's going to do it here. And it's taking a while. It's thinking about it today. When you click on your state, oh, there you go, we'll give you the list of the contractors for that particular state, contact information, and so on. So some really great information in that contractor directory interactive map. That'll help you know where you need to submit your claim. Who is the railroad board contractor? Well, that's Palmetto for everyone, but that'll be listed under your state contacts. Here's that relative value file. Remember, I mentioned that status code B in the status column is going to say this service is bundled. You can never unbundle it. This is that order and referring file on CMS's website I briefly mentioned, and I did click on it to open it. See, CMS does updates to their website on Thursday. It might be why it's a little slow, but this actually takes you to the CMS website, and when you view the data for ordering and referring, this allows you to place a name in here. Let's just do, I'm just going to pick a name, any name, and then show you how easy it is to look up any provider names or any providers that CMS says can refer and order services for Medicare. It also has their NPI number. All right, the Medicare coverage database is here. The coverage database houses all national and local coverage determinations. Those are policies, okay? So that's where you'll find the policies. This I just threw in here to let you know we covered rejections and denials. I revealed the reasons for most common rejections and denials. I discussed how to fix and avoid them, and I provided you with a ton of resources today. Here is a slide. This is typically time for questions and answers. I did mention we would answer these time permitting, but there was so much information to give you. I will let you know how you can send me a question and I will answer it in just a minute. I wanted to mention really quickly this. We are committed to making changes to improve your education experience, and we use information that we gather in a survey to make those changes. And so based on survey comments, just recently we've added chapters to our YouTube videos so you can move from one section of the video to another. So for example, today we covered this and this and this and this in this live webinar. When you go to the recording on YouTube, you're going to find a list of chapters that tell you those 4 things, and you're going to be able to move from one to another. You can move right to the resources. You can move to rejections by using chapters. We've also added training indicators to our announcements for events to let you know if the training applies to you or not. These were suggestions made in this survey that I'm going to talk about in a minute. Also, that survey allows you to recommend topics for future education. One of the requests that we've been hearing from providers is local coverage determinations. On July 15th, we are excited to offer our first Medicare Education Expo, where we are going to focus on all things local coverage determinations. If you go out to our live events webpage, right here, you will see all of those live events and webinars and such. This is that Medicare Education Expo. You can click on it to see what sessions are being offered. You can register for those you want to come to, or not register for those you do not wish to come to. So some exciting things happening. This slide is here because we hear from people who are looking for continuing education units. We don't give you a continuing education unit, but we will give you a certificate that you can use to submit to an accrediting body or organization so that they can consider awarding you with CEUs. There is no separate certificate of achievement that comes to you, but we have a thank you email. It's an automated email that comes from WebEx. And see inside this red box, this is your certificate. It's going to be just verbiage within that email that says you successfully completed today's training. It's going to have today's date. It's going to have contact hour. It's going to have the name of this event. This is what you need to give that accrediting organization in order for them to consider awarding you CEUs. Okay. If you didn't receive this because you joined by phone, you will need to send an email to WPS, tell us you successfully completed today's training, and give us your telephone number you called in from, and we will give you a manual certificate of achievement. You won't receive it in the automated email. You'll receive it directly from us. But it's really no certificate. It's just an email that says you attended. And that's what you need from that automated email. If you joined by telephone only, we will give you that certificate of achievement. Follow-up questions. We didn't have time for questions. We're running just a little late, and I apologize for that. You can email follow-up questions to the same email address you use when you tell us that I joined by phone only and I need a certificate of achievement. Send it with this subject line. And if it is a question that pertains to something I covered today, not claim specific or provider specific, I will send you an email response directly or create a list of questions and answers and send it to everybody. Remember, those claim specific questions need to go to customer service. So make sure you put this, common part B, thoracic surgery, rejections and denials. Go ahead and abbreviate just so that our staff that opens that mail from you knows to send it to me, Mary. All right. Once again, I want to talk about that survey that is so important. Tell us your suggestions. Tell us about this customer experience today. Take some time to let us know how we did today. The survey link is in the chat. There is also one last opportunity. If you've not already taken the survey, there's a pop-up. It's going to look like this box at the bottom of this slide with the yellow triangle at the top. It's going to take you out to a new destination site. You'll see CMS in that highlight area there, in that URL or that link. It's taking you to the CMS website so you can tell them and WPS about your experience today. Remember, this is what affects change. Chapters, the addition of those training indicators, it's all based on that great feedback that we receive from you. Please complete that survey. I'd like that this group be one that completes the most surveys based on the percentage of people that participated. You know, make it so. All right, at this point, I do want to thank you for attending. We know how busy you are. We appreciate your time to learn about things that we feel is important and things that you tell us is important, things that you talk about in that survey. So on behalf of myself and Bailey and all of Provider Outreach and Education, thank you again for participating. We do look forward to those survey comments, and we hope to have you join us for future events. You may now disconnect. Thanks, everybody. Have a great afternoon.